Ryan Stanton here with ACEP Frontline. Today we're joined by Dr. Harry Severance. You don't typically, typically if you're going to mess up, you mess up people's names. You don't mess up the actual qualification, the doctoral degree.
Right.
But that's how we're doing right now. We're getting close to the back end of scientific assembly here. And what we're going to talk about, your talk here, the healthcare workplace, should you stay or should you go? So we're going to dive into that. But first, give everybody a little bit of background about you.
Okay. I'm an emergency physician for, God, more years than I'd like to remember. Have been working in multiple emergency departments, helped start a couple of residency training programs. At my current shop, I've kind of gotten out of working ED shifts, but our department has a division of hyperbarics. So, and I'm board certified through ABIM, and so I'm upstairs above the adult ER doing hyperbarics. I've been doing that since about 2017, but didn't realize until I got into it that when you cover the HBO procedure suite, inpatient, outpatient, you also cover the outpatient wound care center, a clinic. And that has given me a total different insight, expanded my knowledge base on what goes on in hospitals, management, how our business leaders govern the workplace and the workforce, and given me maybe additional insight into these problems that we see evolving with our workforce and our workplace.
Yeah, we've got several pinch points, and for a lot of emergency physicians, it is that, burnout, whatever section. I actually talked about it a couple of days ago that for me, if it's the sick patient, if it's just me and the patient, the sicker, the better. I mean, I don't want them to suffer, but at the same time, if they're going to be sick, I want to be the one to take care of them. And I could do that until I was the patient on the other side. It's really those outside forces that tend to kind of pick away at us during our careers. So that's the idea of this talk. I mean, the challenging and ever-changing work environment. And you kind of dive into that. So let's give us a little primer on this whole discussion.
All right. Now, when we talk about workforce and workplace, it's not simple because it's not a single target. I mean, we can talk about it like we could say, let's talk about reimbursement. Or let's talk about non-competes, or let's talk about administrative abuse, or let's talk about, how that leads to burnout, moral injury. But the problem is you've got to take on the whole ball of wax in what's going on in our workplace, in our workforce. And what I see, if I can find a unifying factor, what's kind of the root cause of all of this, what I believe it is the increasing divide and separation between the people that now run our hospitals and healthcare, the business leaders, and what goes on in the workplace and the workforce, and the fact that these increasingly business leaders feel disassociated and little responsibility for what happens to the patients in the workplace. And I'll go on with that, saying, as we see, healthcare is becoming a more and more, yes, it's highly profitable at the top end. Healthcare is, designed now is going to be the fifth biggest market sector in the U.S. economy. So at the top, there are great profits. It's a multi-billion, if you add in kind of the pharma, insurers, medical mal, all these different stakeholders, you're talking about $1 trillion business. So it's huge profit, but that attracts bigger and bigger business. And we know, just like the individual little small physician group practice can't survive anymore, single individual hospitals and clinics can't themselves stand. So they get bought out by bigger, and they're private equity. But you see this move towards massive corporations, tens or hundreds of hospitals. Who runs these? Well, these big corporate entities bring in captains of industry. You've been successful turning around General Motors, so why can't you do it for healthcare? But my point is these people have no medical background, don't particularly want any. If you look at these big decision-making boards, there are no doctors, no nurses. Yes, some corporate entities require that there be maybe a licensed doctor, but if you go look at the people on the boards, you'll find these are retired. They have no clinical connections, they haven't seen a patient 10, 15, 20 years. And if you ask why, they talk about, we're trying to avoid stark anti-kickback. That's a separate issue. But again, at the very top, no clinical voice whatsoever. If you ask them, they say, well, that's our on-site managers. I've asked the on-site manager, and they say, no, that's what we get guidance from corporate, and they tell us about improving profits, decreasing expenses. Decreasing expenses usually means reduction in resources. They hear little or nothing about, other than keep the doctors and nurses in line. So everybody points in a different way. But what's my point in all this, that little diatribe, is you see from our leaderships little recognition of what goes on in our workplaces. In fact, you look at these they spreadsheet patients now as a commodity. Mm-hmm. And they see us as doctors and our nursing colleagues as we're on the assembly line and we're processing the commodity. So, and they don't even feel any responsibility for the ills and patient bad outcomes. They say that's our job. So I see this increasing divide as the root of all the different things we see going on in our healthcare workplace.
And what we like to do is, it's like a spider web, and we like to find one little thread of that spider web and say that's the reason. And then even if you pluck that web, the web still holds together.
Right.
And, back in the day, most of the hospitals were local, run by physicians or religious institutions or whatever it may have been, or combination of the both. And we're seeing on our side, in Central Kentucky, an expansion of the small independent private groups. But again, even with that, with the consolidations that's there with the system that I work for, there is still a drive to have multiple facilities just to get some safety with you there. And that's a challenge. I mean, we always talk about the fact that emergency medicine is about a physician and a patient. And if you make decisions based on anything other than that relationship and maximizing that relationship, that's going to cause problems. Exactly. Because that's turning it, the idea of which God do you serve kind of idea behind it. And with that consolidation, we are seeing, what I like to call it is the cut to success. It never works. You can't cut yourself to success. Right. You have to invest to succeed, then grow. So how can we start to bridge that gap, as it does seem to be getting larger? We are seeing some FTCs starting to get involved with some of this consolidation and ideas about potentially breaking up things such as Optum or whatever it may be. How do we as emergency physicians, 40,000 of us with ACEP, start to bridge that gap, or at least kind of narrow it down enough that will benefit those that are boots on the ground? Because what I see is that my hospital administration, even the physician side of it, CMOs, those types of things, COOs, they understand healthcare, but they don't necessarily understand what happens in the emergency department. They come down and like, oh, I didn't know it went that way, or oh, I didn't know that was going on. So how do we bridge that gap and start to let people know exactly what the EM environment is like, and how do we improve it?
And that's difficult. I'll go back and point out, in the past 30 years, you talked about how, people come down to the ED, and I didn't know that was going on. There is a lack of awareness among our hospital administrations of what patient care, hands-on, minute to minute is all about. If you look over the past 30 years, I found this fascinating. The number of hospital administrators is increased by 3,200% in the last 30 years, where the numbers of doctors coming on haven't kept up with the numbers of patients. So where do these administrators come from? Increasingly, they come right out of their undergraduate degree or master's in business. They have no clinical background, and they actually don't seem to want any. I talked recently, interviewed and published an article with a mid-level manager who was a little bit older. She was an RN in a former life, left and got into hospital management. She says she feels increasing pressure from her hospital's part of a corporation to increase profit, decrease expenses, get those doctors and nurses in line, get them on with corporate ideals, and with the kind of implied, if you can't do this, we can find someone who can. Where am I going with this? The thing she brought it up to me, and once I confirmed that this is entirely off the record, her name, but she said, I want to see a union at our hospital. Why? Because she said that way she feels very sorry for the plight of the doctors and nurses in the ED in the clinics. But she said unions would give us a seat at the table. Corporate will be forced to talk directly with us, and the mid-level managers are out of the way. They're not being hurt by failure to do corporate goals. So when you ask what changes, I'm not necessarily a union advocate, but I sure see an evolution towards unionization. And thus far, it seems that, yes, we can now get the attention of corporate. Talked to a physician here just yesterday who they had formed a union. They were getting ready to sign the union contract. And all of a sudden, after 2 years, where he said, we don't have enough doctors, we don't have nurses, we don't have resources. All of a sudden, they get a call from the hospital. Oh, we're hiring you more doctors. We're getting you more nurses. You'll have 24-hour CT now. You'll have all these resources they've been denied. So again, is unionization a way for us to recapture patient outcomes and get back to the clinical, what we can do for patients? It seems to be one way. In the long run, maybe not good. Another thing I'd like to do, I would love to see, could we change medical malpractice laws? Mm-hmm. They were written 30, 40, God knows how many years ago. And they were written in an era, like you mentioned, when doctors ran hospitals. And were pretty much liable all the way up for a bad outcome in the ED or the clinic or the OR or whatever. Now we see, and I've even been told by managers that, patient care, and one said to me, no matter what I do, you're responsible for the patient outcomes. Well, what do you mean? Said the law says that. Well, malpractice. And if you go look at malpractice has to address a licensed clinician, a licensed doctor. In most jurisdictions, managers, corporate entities are indemnified. They can't be primarily named. And I've interviewed several lawyer groups and said, they admit they see more and more and more. They see with bad outcomes when you start digging into it, they see basically it's the situation you're working in that has forced these bad outcomes. And I said, don't you feel as a lawyer bad about this? That, you're going after the little guy, the employee? And they said yes, but they said, I thought this was fascinating. They said, we don't have a problem with that. I said, why? And they said, well, as a doctor, if you're working and you're being forced to do things that you believe is causing harm to the patient, moral injury, they said, if you don't get out, you're an accomplice. You're like driving the getaway car from the bank robbery. They said, if you feel your hospital's harming patients, your obligation is to quit. Just thought that's kind of an interesting, but my point is that shouldn't we look at seeing if we could get our legislators to, in recognition of the fact that many patient clinical decisions, lack of resource, all of this are driving bad outcomes, could we change it so that more people at the top are now liable for the bad outcomes that they're enforcing? And I suspect, medical mal, the lawyers want to go for the deep pocket. Mm-hmm. Now that we are more and more and more employees, we don't own the hospital, we don't own the practice, we're no longer the deep pocket. We might find less resistant than we might imagine for legislators taking a good look at med-mal and seeing how we can modify it. My point is that if the people at the top now feel an obligation and responsibility for what patient outcomes are in the workplace, maybe we can change their ethic from it's a commodity to these are patients, these are live people that need good outcomes. So there'll be a couple of things that I'd look at.
Yeah, it reminds me of when we talked about the opioid epidemic with SACS and all the groups there with the opioid epidemic, and the fact that their upper tier advocated, got protections for their leadership while they knew that the medication itself was addictive and was going to cause deaths. And it wasn't until there was more and more and more and more pressure that they actually started able to go after those over those leaders, Sackler.
Yeah.
I didn't put the last letters on there. So Sackler. And so as we wrap up today, kind of give a little bit of a summary message, from your talk or wherever it may be, that for physicians out there kind of navigating these situations, because I mean, for most of us, it's not a, take your ball and go home, get out, like the lawyer may have mentioned,
Right.
Because honestly, for us, the environment's the same in almost every facility now.
Exactly.
And it's just not so simple to uproot an entire family and stuff just to try to move and find the one place that's got it.
Right. We've talked about system changes, system reset. Those are not easy. So what I do as a kind of sideline, and for the individual doc or nurse or others, is if you're waiting for the system reset while you go to your clinical workplace each day, get beaten down, we see the incidence of mental illness, of suicide among us increasing at a horrible issue. What I try to do is say, while we're waiting for the system reset, how can I help you as an individual doctor or nurse or other healthcare professional, mid-level, in your daily career? What can we do to help empower you a little bit, to give you options, maybe sidelines, other, how could you take your skill set and maybe switch it a little bit and do something different without having to restructure your whole life. A lady told me yesterday, I was talking, she said, "Oh, you mean work smarter, not harder." I said, okay, that's one way of looking at it. But that's what I try to do, is try to help people in their workplace see if they can change a few things and make this a better lifestyle for themselves and their families.
Interestingly, we've had our discussions last week with our administration. One of the things we were able to do is demonstrate some of the changes and things we have done to help bridge the gaps in the system with regard to staffing and access and bed availability. But we actually then pulled it in terms of benefits and dollars that it has meant by what we have done to bring into the hospital. And it seemed to actually get the notice in the eyes of saying, wait a second, we would have lost that if you guys hadn't have done it. They're like, yeah, this is what our group did, and you're benefiting from it. Now help us to continue to do it, because we can do more. And and I think that's a lot of it, is demanding and pushing for face-to-face with your administration, showing what you're doing in the EED, because if it is a large enough system, the administration may not even be in a hospital.
Right.
They may be in a corporate building somewhere.
Exactly. They're on the other side of the country.
Right.
Yeah.
And so, I mean, that's the key, is getting that face-to-face with those leaders to help them understand. And it's not going to be perfect. I mean, honestly, I don't think anybody's ever been in the healthcare system and says, this was a perfect day. There's been great days. There's been really good days. But there's always room for improvement.
Exactly.
How can folks get in touch with you if they have any questions or want to dig in further?
I'm on LinkedIn, on X. I've got my main email address is my name, harry.severance@gmail.com. So there are multiple ways, and I'm happy to always chat with people and see how I can help.
So an early Gmail adopter, no bunches of numbers at the end of that.
No, I was long ago. Yeah.
Yeah, same here. Ryan A. Stanton at Gmail. Talking with Dr. Harry Severance here at SA in Salt Lake City. And as for me, you can contact me, rstanton@acep.org, rstanton@acep.org. Make sure that you are downloading the podcast on whatever your favorite player is. And do me a favor and give us a 5-star rating. Comments, we love it. Help boost us up, get that information out there to our docs around the country and around the world. Until next time, I'm Dr. Ryan Stanton, and this has been some ACEP Frontline.